don't think Danny Lorden was going to join us. He's traveling now. Okay. Sarah, Adam, Representative Schmick, Cara Towle. Cara, we're in your house. You should be here. Okay. And I know Representative Riccelli couldn't join us today. Okay, so those are all the people officially in the collaborative. If you want to introduce yourself, please do so now.
John Bose from Labor and Industries.
Great, thanks.
Hi, this is Tracy Drake from the Department of Health, Office of Health Professions.
Vivian Klein with the Senate Healthcare Committee.
Lisa Roach with Providence System Telehealth.
Hi, good morning. Stephanie Cowan with Multicare.
Hi, Leslie Emmerich with the Washington State Hospice and Palliative Care Organization and the Home Care Association of Washington.
Hi, Leslie. Going back to Jackie. Jackie, do you know if anyone else from Multicare is going to be joining today?
No, just myself, just Stephanie.
Okay, okay. Was that Stephanie? Okay, sorry, I thought you said Jackie. Stephanie, I should know your voice better by now.
Yeah.
Okay, thanks. Anyone else want to say hi? Okay, let's just see if there's anyone on the chat who wanted to say hi. We have Dr. Michael Matella from the Everett Clinic. And he just wanted to say hello. He's in a public space, so didn't want to get us to the background noise, but he just said hi. So welcome, Dr. Matella. So I think unless there's anyone else who wants to say hi, we'll get going on the agenda. And the first order of business is to review the minutes from last time. So I'm just going to share those minutes and do that right here. Agenda today. Okay. So last time we were hosted by Senator Becker, Representative Riccelli down in Olympia, and we reviewed some of the training that was going on, and we're going to have a little bit of a follow-up there. And then we talked a little bit about the telehealth parity as well. And I think that was the majority of our business. We did talk a little bit about store and forward, and then we had a public comment period as well. Just see if there's any edits or additions that we need to put on the minutes. Okay. Well, can I get a motion then to approve these minutes?
That motion, and by the way, nicely done on the minutes.
Yeah. Thanks, Rob. Can I get a second? Thanks. Discussion? All in favor? Aye. Say aye. Anyone opposed? Okay. Thanks. I think we'll upload those then to the official website. And thanks for everyone's getting the slides to us. I think is really helpful. And any kind of document ahead of time makes our lives a little easier. So the next thing I wanted to talk about is training. And let me just show this slide with that. Sarah, I don't know if you want to kick off the discussion or.
Sure. So an action item from our last meeting was that I was going to meet offline with Senator Becker because she had a concern that the previous draft training deck was very limited to just MDs, and so we identified that this should be more open to all provider types and not limited. So that was one of the action items and changes that you'll see in this slide deck.
Yeah, let me buzz down to that. Sure. Looks like what slide? It's right here.
And I think I heard Senator Becker was late. She's running. Okay, so she might have more to add about this. But you know, there are a lot of different kinds of provider types. So what we did was try to reference a few of the most common, and then also link to, if you go there to the next slide, yeah. So there's a note at the bottom, there are additional licensing types here in the state of Washington. Here's where you go for more information.
Yeah, and I've reached out to the boards for a lot of those groups. I've reached out to like the OT group, the PT group, speech therapy, and a couple of them have responded, and they're kind of trying to refer me to their telemedicine expert. I think it was the PT group actually had a policy as well. So once that's available, I'll put that link in there as well. But that, I think for now, that's probably going to be a pretty good resource for.
Great, yes. So there are two areas where there are multiple provider types that are referenced. So licensing requirements is of course one, and then standards of care are another. So not all of these, but some of these have some standards of care defined by their national advocacy groups for what should or should not be done with telemedicine visits. I just put a couple of the common ones in the deck again and said check with your group for whatever specialty that you are. Some other things that we've added, so I worked with Dr. Scott and Denny Lorden to go through the deck and make it more comprehensive. And Lena Rubenstein from our team back there helped put a lot of this together too. So we added the multiple provider types, additional billing requirements. We here. What billing documentation is needed when you're submitting a claim for telehealth services. We also added more information to the credentialing and privileging section. So what is credentialing? What is privileging? What's the difference between hospital-based credentialing and facility-based credentialing, and then payer credentialing, and what do you need to know for telehealth? We split up the reimbursement section to federal, so Medicare, and then Medicaid, and then Washington private payers, so that it was a little bit more intuitive, and had some more information in there. We added a lot of hyperlinks throughout the document so people can go get more information if they need to. And we also added some basic pictures for your web presence and website manner towards the end, things like how to adjust the lighting, what angle should your face be at, make sure you're in a private space, there's no one lurking around the corner, the patient sees it in the camera, those kinds of things. Yep, there you go.
I liked some of the pictures you guys included here.
So those I took from the regional telehealth resource center. Yeah. So they're great. We also put in here a provider checklist at the very end. So this is a whole lot of information. What's the most basic checklist I need to go through? Stark and malpractice were added. And Stark and malpractice, I got the information mostly from the Center for Connected Health Policy. And but my recommendation for next steps for this slide deck would be that a lawyer review it before we make it official and public. Because I do the best I can, and I'm a former regulator, but not a lawyer, so that would be great.
Alan, would you mind? Yeah. I'm teaching a law school class. But yeah, and there may be some stuff from your presentation today that sure. From that as well.
So again, based on our last conversation at our previous meeting, the premise of this slide deck would be to make it available as publicly as we could. Whoever's willing to partner with us, we were exploring making this a CME requirement, or making it into a CME. And then also, not mandatory, but it's there if you need it. So most health systems, big health systems have some of these things already incorporated in their trainings, but here's a very basic, quick overview.
And I had reached out to Micah Matthews at MQuack to see if something like this could be living on the MQuack website. I haven't heard back, but I know that his colleague Ms. Drake is on the line. So I'm wondering if Ms. Drake, if you wouldn't mind commenting on the deck, and if this is something that you feel that MQuack could just make available to doctors who are interested in this.
So can you hear me?
Yeah, go ahead.
Okay. So I am not with MQuack. They are a separate division within Department of Health. I'm with the Office of Health Professions. So there's the Nursing Commission and there's MQAC and the Chiropractic Commission, all in the same building, but they have their own rules and regulations. I would represent all of the other health professions besides those three. And I would say there's a good chance that it would not be an issue to put information like this on a website, to have a link to, a telehealth page where we could probably put this on the main web page for overall telehealth for the health professions. It would be something that would have to be reviewed by our communications office to determine that, it was all acceptable to them. But it would probably not be an issue, and it could either be under the individual health professions or under Department of Health overall.
Okay, thank you. I think the other thing I might suggest is just put this as part of on the WISHA website as well, where all of our notes and stuff are housed there too. So there's multiple places that people could access this. Other ideas on how we can disseminate this? I mean, this is something that we could maybe give to the
no doubt.
Washington State Nursing Association or WISMA. What do you guys think about that?
I'll definitely take it back to WSNA.
Okay.
I had one recommendation too. I'm working on a steering committee with the American Nurses Association. We're just finishing a set of principles for telehealth, and that would be a great. They have a whole team of people working on telehealth, so I think that should definitely be. I can send you a link. Yeah.
So in terms of next steps, I think that I would just ask people to read this. If you haven't had an opportunity to read through it really carefully and send me any edits, Adam, if we could get careful attorney eye and make sure I'm misrepresenting the law, and that'd be great. And then we'll hopefully post that to the respective places we talked about. I don't know about the CME. How that gets granted. I'm familiar with their process here, which is not easy and not cheap. So I'm not sure we're going to be able to support that.
So one consideration is at least a certificate of attendance. And you could have a couple of people go through this and determine how long it takes. Say it's an hour, then you could provide a certificate of attendance. So you don't have to go through all the accrediting steps and maintenance of accreditation, but people can still download. But that's very valuable for nurses, by the way, and other professions for renewing their licensure in the state of Washington. So that would be a motivation to actually go for it. You don't need accredited CNE to maintain your license in the state.
How do we verify that everyone's gone through it, seen all the slides? I mean, I'm familiar with doing an LMS module where you can actually see that they've looked at every slide, and there's usually a quiz built in.
I was going to say quiz.
That's
Midway.
Yeah. And then who keeps track of that?
Who owns it?
What's that?
Who owns it?
Yeah, who owns it? Yeah, exactly. I mean, it's probably I don't know if that's collaborative. I know that MQAC has been close to kind of own it.
So no one has to own it if it's just a certificate of attendance. More of an honor system that you attended.
Okay, that's what you're thinking.
Yeah.
Okay.
Right. It's not at all of the other business.
Okay. So then what you can do is just have a certificate at the end. That's the last slide. And then
yes. And you can build into the LMS if it's sophisticated enough where they can't just flip through all the slides. They have to go through them, and they have to spend a certain amount of time on each slide. So that they can't just go, yep, I saw the deck.
Okay. Well, at minimum, we can add that certificate slide.
What LMS are you thinking? What platform are you?
Do you know, Carl, what do we use here? I know it's not easy to do LMS here. They often have to pay for it. It's not an automatic process, unfortunately.
Is that through Joan Reisland? Through the education department?
I don't know that name.
I have to dig up my contact.
Okay. But we can talk offline about it. I'm happy to.
Okay.
I can also check with the Stanley and see any calendars. Just out of curiosity about the costs.
Do you do it through the, do you have a, so the learning management system that all the School of Nursing education is on, it's very sophisticated and can be very interactive. And I bet John would love, I mean, it would drive traffic to that place. I assume, is there another entity that is hosting education online and during activities?
I mean, I know like within the Department of Psychiatry, we do use LMS system for
But to answer your question, I don't think that the School of Medicine, School of Nursing necessarily use the same LMS.
Yeah, okay.
I think that's your question.
So we should also approach the School of Nurse. You know, they've got volumes of education going on all the time with the sophisticated LMS. So, okay.
And my preference is that we make it easy and we make it cheap. Yeah. My experience has not been either, unfortunately. Okay, so we'll work on that, and I'll look back with Micah to get this on the MPAC site. And thanks everyone for pitching in. I think this will be a great resource for providers out there.
What's our goal in terms of at least dissemination and going live with ASAP? Like for editing and.
Yeah, I mean, if people can take a look at this, this week, and make sure there's no errors, and if there are, just send them back to me and Jamie. We can correct those. And then, the three of us can kind of look at LMS opportunities. But it's very easy to post to the various websites. But definitely can get this to Wisha right away. We're pretty fast about posting that. If you can look at WSNA and I will look at WSMA.
Right, and I'll also be on a call with the executive director of the Nursing Commission tomorrow, and I can also ask her if they would love to post it at their website. So I'll check it.
Okay, so maybe some of these boards also, like the pharmacy board, PT board, OT. I mean, I imagine they'd love to have that. Great room.
And quick question, this might be a silly question, but what about veterinary medicine and dentistry? Are we reaching out to these entities, or is that out of our scope?
Hey, this is Tracy Drake. And I just, they're all within our office, the veterinary board, the dentistry. I actually work with the dental commission. That's my actual commission that I represent. And any of those would be ones that would be open to this and something that they might want to put on their webpage. It would be up to the individual boards and commissions to make that decision. But all of them are looking at telemedicine. It's something that everyone is talking about. So it's something that they would probably be really happy to look at and have something they can offer to their stakeholders to put on their webpage.
We did add dentist to the licensing requirements, and I'll link to that. I think a January timeframe to go live would be really great because we did update the Medicare guidelines based on the new payment changes, and we had that link with the intention of reviewing this at least annually. That's why we added the version date at the bottom, so the collaborative could look at this annually. I don't see an issue if something comes up in a year and people want to change. We could change it whenever, but no less than half.
Dave, can I ask you from OCHIN, is there any advice you'd give us for disseminating these kind of best practices? You guys work with CTM.
I'm thinking about that. They have obvious connections with a multitude of clinics throughout the state. And so I think there might be able to at least disseminate links or point to access.
Okay. Do you want us to give this to you and you guys can also be a disseminator since you're working with a lot of those? And then, Carl, what do you think about the NRTRC? Also, be a resource there. Make it free, make it widespread. Okay. I think we've got a lot of potential outlets for this. Okay, well, thanks everyone. So the next thing I wanted to do is ask Adam Romney to tell us a little bit about credentialing, in particular this issue of proxy credentialing. So Adam, let me pull up your slides and I'll just advance them if that's okay with you.
Sure. So as Sarah mentioned, these words can be used in many ways.
privileging and credentialing, credentialing or privileging by proxy. This slide deck is narrowly focused on hospital credentialing, and so it's dealing with the concept of the legal requirements imposed on a hospital when it engages physicians either through services agreements or employment or any other type of arrangement to provide services to hospital patients. Whenever that's done, the hospital has an obligation to verify the credentials of those physicians and to issue professional privileges to those practitioners so that they can treat hospital patients. So when telemedicine is involved, there's some shortcuts that have been put into place that we're going to talk about. And that's the kind of narrow topic of this deck. And so it doesn't deal with payer credentialing, or I think Sarah mentioned clinic or other facility credentialing. We're narrowly focused on the hospital element. So like one example would be a critical access hospital hiring. I'll use the example of Nighthawk. Most people know who Nighthawk is, the after hours, I guess they're 24/7 radiology company, or like a telestroke company, or even another hospital to provide physicians to furnish telestroke professional services to those patients who come to a critical access hospital. That's the privileging credentialing category that these slides address. So this first slide talks about what that hospital's options are for privileging and credentialing those hired physicians. There are really three options. Option one is to go the traditional route of that hospital subjecting the physician to its own full credentialing and privileging processes that are in its bylaws. So that own hospital doing the credentialing and privileging work itself, as it would with any physician that it hires. Option number two is to ask the, I'll call the telemedicine company to furnish information to allow the host hospital to do the credentialing work. But the telemedicine company is out there gathering original source licensing information, national practitioner data bank information, all information that goes into a credentials verification. So the telemedicine company furnishes the information, the host hospital reviews it, and either says yay or nay, they pass our credentialing standards or not. The third option is that the host hospital does not do the work. They rely on the credentialing and privileging decisions made by the telemedicine company. And that company, again, could be a medical group like Nighthawk, or it could be a health system. So the recent, I guess not so recent now, but the 2011 changes that Medicare made allow the host hospital to rely on those decisions made by another entity. So you have three choices if you're a hospital engaging another to provide you with professional telemedicine services. So we're really focusing on that third option. What does that mean to take advantage of this shortcut and allow your hospital to rely on the decisions made by another entity? This slide kind of summarizes what this telemedicine credentialing or credentialing by proxy, what it means. Again, I think I kind of already described this first bullet, that the Medicare conditions of participation require full credentialing of all physicians who furnish services at your facility. And telemedicine practitioners are not an exception to that. In 2011, like I said, CMS created this exception to allow the hospital to rely on the privileging and credentialing decisions made by another company. So if we go to the next slide, the main legal topics to consider are these. So the Medicare conditions of participation requirements is if your hospital is accredited by the Joint Commission or DNB. They have very similar but slightly different requirements than the Medicare conditions of participation. The third legal topic is the written agreement that your hospital has with this telemedicine company and what that must contain. Number four, a lot of states have within their hospital licensing laws, they have some language regarding telemedicine credentialing or credentialing by proxy. And fifth, the fifth item is keeping an eye on your medical staff bylaws so that you are sure that your own bylaws are flexible enough to allow your hospital to credential and privilege in this way. So talking about this slide just kind of ticks through the CMS conditions of participation that apply to proxy credentialing. Again, a lot of it focuses on the existence of a written agreement between the hospital and the telemedicine company. Part of that agreement and part of the regulatory requirement is that the telemedicine company has to engage or has to conduct the privileging and credentialing in a manner that complies with conditions of participation. So let me give an example. So if we use the Nighthawk example, that medical group has to develop a process, a hospital-like process for reviewing the credentials of radiologists that it hires and privileging them, which is a little bit of a strange concept for me that a medical group assigns a privilege to a physician, because I don't think of privileging as a medical group function. It's a hospital function in my mind. Nevertheless, that's what the conditions of participation want. If it is a non-hospital entity like Nighthawk, they have to develop a governing body. They have to develop policies that mimic what a hospital would do to review the credentials and assign a privilege to each radiologist that it hires. Once you have this written agreement in place, the telemedicine company, again, I'll use the Nighthawk example, they have to provide a current list of its credentialed and privileged physicians to the hospital. And it has to provide that kind of on a regular basis, so that list is always current. So that if, let's say, a physician falls out of, let's say they haven't renewed their privilege with Nighthawk, Nighthawk has to then inform the hospital, this individual is no longer privileged with us, therefore you can't rely on us for that person to be privileged with you, because if you're relying on our decision, they've fallen out of privileging at our level.
One way that I've heard to get around is to say when the contract expires, don't they have individual contracts with those providers? Or
They do, but it's also, I mean, you know, if you think about it in a hospital context, you could have an employed physician who has an existing employment agreement, but they have, for whatever reason, failed to maintain a privileging requirement, and their privilege could fall out of current status. And that could happen at the medical group level as well. They could still be hired by Nighthawk, but maybe they didn't report, I don't know, a malpractice claim to Nighthawk, and therefore they're in breach of their agreement, and they're in breach of their privileging status, and that could then be in jeopardy. So the written agreement has to have some process for maintaining that list between the hospital and the group, or the hospital and the other hospital that's selling the telemedicine services. So something like, you know, this list will be updated anytime there's a new name or a name removed from it, or something like that, or upon the hospital's request. That's something that often falls out of, people don't watch that as closely as they should. That's a compliance item to kind of keep in mind. So there's also a role here for the host hospital or the recipient hospital to play. In order for, and I'm just going to keep using Nighthawk, in order for Nighthawk to be able to adequately assess the qualifications of these radiologists, it has to know about any complaints that might arise at the host hospital. So the host hospital has an obligation to report information back to Nighthawk about any complaints it may have received, or any adverse events, or any kind of poor performance reviews or quality issues that may have arisen at the hospital involving that practitioner's care. CMS, of course, requires that the telehealth practitioner be licensed in the host hospital state in accordance with that state's law. I mean, as we don't have this issue in Washington, but in a lot of states, or in some states, you know, they have a special telemedicine license. It's slightly different than a full physician license. I already mentioned that one about internal review and providing information and adverse events. Okay, I already covered that. Okay, the bullet I skipped is, I'm sorry, I skipped the fourth bullet that talks about the telemedicine company being either a hospital or a telemedicine entity. And this is a CMS word that it kind of invented in 2011. And it's the idea that not all vendors of telemedicine services are also Medicare participating hospitals. It could be a medical group, and those medical groups may or may not participate in Medicare. And so it creates some flexibility for a hospital to hire or to engage telehealth practitioners from a variety of different types of vendors who are selling telehealth services. It's a kind of very open word, telemedicine entity, that's intended to provide some flexibility for a hospital to when selecting other entities to purchase telemedicine services from. So Nighthawk would fall into that telemedicine entity example, or a direct-to-consumer company would fall into that telemedicine entity example if a direct-to-consumer company is being hired to provide services to hospital patients. Okay, so this slide gives some tips for the written agreement between the telemedicine company and the hospital. Again, you have the basic requirements in the prior slide about exchanging information. Those things, of course, need to be there. But one thing that's important to remember if you are the hospital is that this is your compliance requirement. If there is a CMS certification survey, it's the hospital that's being surveyed. It's not the telemedicine company. So if the telemedicine company has done something wrong, it's the hospital that's on the hook. It's like anytime the hospital is hiring a vendor, it's really the hospital that's responsible for what the vendor's doing. And that's the same situation here. So it's, for example, if that telemedicine company is not performing a privileging and credentialing process that complies with Medicare requirements, that's a problem. That is the host hospital, that's the host hospital's problem. It now has physicians that have not been through a compliant credentialing and privileging process. So you really want something in the contract that holds that telemedicine vendor's feet to the fire and says, you know, you represent and warrant that you will develop and require those physicians to go through a CMS compliant credentialing and privileging process. And if you don't, you're responsible for the fines and penalties and losses we might incur because of that. They will, of course, push back on that, but that's the truth of it. If they have not complied with that requirement, and the hospital may suffer losses due to their noncompliance, and you would want some ability to recover those back from the telemedicine vendor. Also, you know, you are relying on that telemedicine company for all credentialing items such as licensure. If a physician falls out of licensure, again, I'll pick on Nighthawk. I mean, they're a good example. They've got tons of physicians licensed in 50 states. So it's not unfathomable that one state, you know, maybe someone forgot to file something in Washington and a physician, radiologist lost his or her licensure in Washington and saw a patient at your hospital. If that comes up in some kind of survey, the hospital, again, it's the hospital's compliance requirement, and so you might have a enforcement penalty due to that. You would want to be able to go back to Nighthawk and be made whole due to their error. So kind of thinking through, how do we make sure that we keep this vendor or make the vendor accountable if they mess up, basically. We talked a little bit about the exchange of information. It's helpful to have in the contract some processes that are spelled out to have that information exchange about complaints or adverse events that might have involved that telehealth practitioner. When and how will those be communicated to the vendor? And when will the vendor provide, when and how will that vendor provide the current list of privileged and credentialed practitioners to the hospital? Spelling those out in the agreement helps to kind of set expectations. The third bullet is also something important to remember. These telehealth practitioners are part of your medical staff. So they have to be integrated in the hospital's everything. You know, in your quality process, in your utilization review, everything that you subject your other physicians to, these physicians are part of that, or should be part of those processes unless there's a reason not to. But for the most part, Medicare conditions of participation involving, you know, QAPI or outpatient services apply to the full medical staff. So you can't think of the telemedicine physicians as separate from those other hospital review functions. This fourth bullet really relates back to the first. If the telemedicine company does mess up, do you have an indemnification provision where they would be held responsible for those losses? A lot of the telemedicine companies will try to limit their financial liability for breaches to a certain dollar amount, or or in some way, and you really don't want that. I mean, you as the hospital want to be made whole if there is some kind of loss that you incurred due to their noncompliance.
Adam, before you move on, I just want to make sure people understand some of these abbreviations at the top. Sorry, so COP is conditions of participation. That's a CMS thing, right? And TJC is the Joint Commission. And then DNV, I forget what that stands for.
DOS, it's Latin.
It's Latin.
Yeah. I don't remember.
Is it Latin or is it Northern?
Oh, it's like Scandinavian.
Yeah, Scandinavian.
Yeah, that's right.
A region. I'll look it up. It's the accrediting body for hospitals.
So there's two different accrediting bodies. Most places are under the Joint Commission, including UW Medicine. I think Children's is different. You're under DNV.
And Swedish is under DNV.
You're under DNV. So the only reason why I mention that is that sometimes you have to make sure that that's clear in your agreements, that if you're working with another hospital that's not under the same commissioning or body, that you spell that out. Isn't that right? Please run
the
into
next
that.
slide, Dr. Yeah, but that's right. I mean, this shortcut method of relying on another entity's privileging and credentialing decisions, that this shortcut is part of CMS conditions of participation and Joint Commission standards and DNV standards. That's why I say make sure that the process complies with either the COP, Joint Commission, or DNV standards, because you as a hospital have to, you will be surveyed to confirm that all physicians have been credentialed and privileged in accordance with those standards. So, but yeah, those are, that's what the abbreviations are. So the next slide highlights this issue, that a lot of times you have arrangements between entities that are certified by different organizations. So so a little background, in order to participate in Medicare, you have to be certified, which means either the state has to come out and confirm that you comply with Medicare COPs, or you sign a contract and pay Joint Commission or DNV a fee to have this deemed certification status, which means that if you are accredited by one of these two organizations, you have met all of their accreditation standards. Medicare says, okay, we won't survey you through the state. We'll rely on the Joint Commission or DNV accreditation, and you're good with us. You can participate in Medicare through your deemed status, through your accreditation. But Joint Commission standards and Medicare conditions of participation are not mirror images. There are slight variations between them. And this has come up in connection with the telemedicine credentialing standards within each of these three organizations. The place where I've seen it come up, for example, I copied it here, is the Joint Commission standard that talks about this very process. So if you look at the bottom bullet on this slide, it says the originating site hospital may choose to use the credentialing and privileging decision from the distant site to make final privileging decision if the distant site is a Joint Commission accredited hospital or ambulatory care organization, which would mean that the hospital could only hire another organization to provide telemedicine if it is also a Joint Commission accredited hospital or group. Now, this has been the subject of a lot of discussion with Joint Commission. Do you have recent experience with
Yes,
this?
we do. We just provided tele-ICU to Holy Family in Spokane, and their Joint Commission's in DNV.
Yeah.
So we had to, we needed to hurry up and get it done quickly. We had about 6 days to get everything done. So we had to quickly go through all of their credentialing, provide all the documents to them.
and then they went through the whole process, so they didn't accept ours by proxy.
Oh, okay.
Just a regular credential.
Yeah, it was.
So you kind of went with option 2, where you
Yeah, well,
provide all
it was
the.
sort of our back was against the wall, and
Yeah.
they were losing their providers, so very quickly, and it was a really challenging process.
Okay.
My understanding is that the Joint Commission over the past, I'd say, 4 months had recently adopted some changes that will go into effect in about 9 months that more closely align with the DNV accreditation telehealth standards, so that it will become easier for organizations to do the by proxy credentialing. I don't know all the details on it because it went a little over my head, but
That's basically right. They're working on relaxing this so that a Joint Commission hospital could hire anyone so long as it is a CMS compliant privileging and credentialing process. And if you encounter that again, you can't, we did have one situation where we received written approval from someone at the Joint Commission to say, even though that vendor is DNV accredited, you can use them. Even though right here in our standard it says it has to be Joint Commission. So with a little bit of back and forth with the Joint Commission, we've gotten them to be lenient on this, given that they are looking to update the standard. Yeah, I can give out a name if you need. Yeah.
I know I hate being late to something when this is so critical, but I'm sorry, traffic was a nightmare. But when you're talking here on this slide, it talks about independent providers. Are you saying then independent providers have to go through a Joint Commission or a DNV standard process, individual providers, and instead of a facility hiring them as employees, can they contract with them?
If they contract with them individually, or if they contract with their employer, that physician or that practitioner has to be credentialed and privileged.
At the hospital?
At the hospital.
Yes, like normal.
Like normal.
Okay.
Yeah.
And then if it's with a group, say a surgeon group that's independent of the hospital, they'd have privileges at the hospital, but would they have to go through a separate process to become telemedicine credentialed?
No, they can go through this streamlined process that we're talking about. So, for example, that separate group can develop its own group credentialing and privileging process, and the hospital can rely on that. And they won't have to go through a separate hospital-based credentialing and privileging process. They can say, you at the group, you credential and privilege them. That's good enough for us. So long as all of these, there's that written agreement in place, all these compliance items are met. So it's a way of short-circuiting privileging and credentialing for hospitals to make it to increase access through telemedicine. So again, that accrediting organization issue is just a reminder to keep an eye on what your standards are and what the standards are of the hospital or entity you're engaging to be the telemedicine professional provider. Okay, the next item is state law. So a lot of states have state law, and our state does too, about the hospital must maintain a medical staff that medical staff must, and members of the medical staff must be privileged and credentialed. Our state does not talk specifically about telemedicine credentialing. Other states do. My bias is that it's just another place to add confusion, frankly. For example, in California adopted within its state hospital licensing laws a telemedicine credentialing, some telemedicine credentialing language prior to 2011, prior to when CMS adopted its requirements. The state law in California was more rigid and more strict than what CMS allowed. So there was this period of time in California when, although Medicare said you could do it, state hospital licensing law said you couldn't, which is really so California, frankly. And it took a long, and again, it was so California, it took a long time to work that through the regulatory agencies for them to issue a letter to say, okay, we're going to change this. We're going to make it CMS compliant. If you comply with CMS, you comply with state law. So ultimately, they changed their section of the Business and Professions Code to say, You know, if you have a process that complies with 42 CFR 42, you know, the Medicare standard, then you're good under state law. Another example that Sarah shared with me was from Maryland. And it also relies on the Medicare standard to say that if you comply with the Medicare telemedicine credentialing regulations, you comply with state hospital licensing law. One thing I found really interesting, though, was that it only identified physicians. I don't really know why that's the case. But as we know, in our state and many others, a lot of other practitioner types that are on medical staff and providing telemedicine services. That's why I say, you know, I don't know, again, this is just my bias. I don't know that it adds a whole lot to, you know, for quality purposes or for efficiency purposes, if Washington was to adopt a hospital licensing law that discussed telemedicine credentialing, but maybe someone has other views on that.
I can tell you in the state of Maryland, because
Yeah.
I worked a lot on this. First of all, that word physician, looking back, was not debated. It was probably one of those words thrown in there in an unintended consequence. You know, these days I would recommend something like a healthcare professional, right? Not limited. But also in Maryland, they had, you know, some rural hospitals that were very hesitant to do telemedicine credentialing by proxy or privileging by proxy, and having this extra state law that says, okay, yeah, guys, you can do this in our state. That gave them the confidence to be able to move forward with it. So that was kind of the benefit there. And then that helped a lot of the hub hospitals really start to kick off their programs to get to the more rural regional hospitals.
See that? Yeah, if there's some ambiguity or question under state law whether you can do it, the Department of Health clarifying that would be really helpful, or the legislature. It's not I don't know, does anyone think that Washington has that issue, that people are unclear in Washington whether we can do telemedicine credentialing? Yeah, so, yeah, that's not my impression either, but yeah, in Maryland is also a special state with Medicare because it operates under a massive waiver, so.
Yes, the all-care system. And but they also have physician licensing reciprocity with Virginia and DC, so it gets even more complicated.
Okay, the last, I think, legal topic is hospital bylaws. Again, you have to operate in accordance with your bylaws and privilege and credential in accordance with your bylaws. So your bylaws might need some tweaking to allow for this process. It's also really good as a medical staff to discuss whether you're comfortable as a medical staff relying on privileging and credentialing decisions of others. You know, when are we comfortable with that all the time? Are we comfortable? Do we want to talk about who the vendor is first? A lot of times with my clients, you know, they'll be approached by a vendor saying, we can do telederm for you, this great program or something. And the medical staff is kind of a little caught off guard trying to decide, okay, do we want this? Are we going to rely on them for privileging and credentialing? Do we want to own it? Do we want to see every physician coming through and look at their credentials specifically? So I find it helpful to have a little bit of advanced discussion so that the medical staff knows when it will, you know, use option 3 and rely on decisions of another, or when it will use option 2 and review the credentials itself. I think it's a positive discussion to have at the medical staff level. Also, the last bullet on this slide, you know, I'll go back to Nighthawk. So, you know, they will say these 50 physicians are, you know, carry a teleradiology privilege. You may not have that at your hospital. You kind of have to think about, and maybe you've been through this and have a strategy for this, but you kind of have to think about, okay, are we going to have specific specialty telemedicine privileges like a teleradiology or teledermatology or teleneurology privilege? Are we going to have a broad telehealth practitioner privilege that could be applied to any specialty type that we may want to hire? And that will require a little tweaking within your bylaws to accommodate for that that new approach to privileging.
Can I say two more things about your hospital bylaws? I've kind of been in the thick of it lately. And those are due process, and then whether you retain the authority to discharge someone. So give you the example, say you have an outside group and they have absolutely no concern about a provider, but for whatever reason, they just haven't clicked with your hospital, your patients, and you actually have some real concerns to the point where you would like to fire them and just kick them off your privileges. I think that's something you probably want to have in your bylaws.
Yeah.
Then the flip side is if you're a regular provider, you would have access to a hearing. It's called due process. And you have to think very clearly whether you want to have that process, because in theory there's the due process at the outside facility as well, and whether you want to have 2 layers on that is another thing to consider. And it's a little bit complicated, but you need to really think about those things.
And this may be a little off track, but one thing we try to do to short circuit it, because you're right, once they're on staff, they have some rights, right? And there's some due process that kicks in for medical staff members if you're going to kick them off the staff. One thing we've tried is that this is still largely a services contract between a hospital and a vendor. And if you build in some terms into that services agreement to say, the hospital really has the ability to schedule and say who should be on the schedule and who shouldn't. And rather than triggering this entire due process that might involve 2 hospitals, you can kind of work through that scheduling language to say, if we express concerns about, Dr. X in 2 consecutive months or something like that, or there's, we will meet and confer and talk about this concern, but ultimately the hospital controls who's on the schedule and who's not. That's kind of a
Ready in the contract.
Sneaky lawyer way of doing that. Because you're right, it is very cumbersome to, for these somewhat part-time providers, they're not there 40 hours a week. They're servicing, but potentially servicing 10 hospitals to trigger a peer review due process situation. So we try to deal with it contractually at times.
Francis, did you ever encounter this when you were at Karina? Any of these kind of issues? Or no?
We never had it. Actually. I'm just trying to think. We went through a similar process, but a lot of it too is through small, facile. We had a lot of direct communication, with the provider organizations they're working with, and they work pretty much exclusively with the health system and not with the payers. So it was a very tight, focused relationship, and maybe that was the reason that we really didn't have a lot of issues. I think partly too, they have a very rigorous training program and high standards, and so that really mitigated, I think, a lot of maybe poor care that would then trigger these kinds of conversations. And also, that group was totally invested in telehealth. They weren't moonlighting. I think that makes a big difference too. Just to your point, you've got, docs or providers or practitioners that are working from multiple different systems. That can lead to issues that we just
Adam, again, I'm sorry I was late, but you're talking about hospitals credentialing and telemedicine credentialing. The carriers also go through a credentialing process. Do they have to address the telemedicine differently or in the same way that the hospitals have to address it?
It's different. Yeah, CMS and Medicare have very specific privileging and credentialing rules if you're going to participate in those programs. I frankly don't know if there is law regarding health plan credentialing of telemedicine practitioners. I don't know.
We do not currently have a separate credentialing system for telehealth providers. If they're credentialed through the standard processes, then it's just basically then an identification of where, like the traditional modifiers in terms of the billing side. But from the credentialing side, we don't have anything. Have not to date anything that's special. Thank you.
For the folks on the phone, you may not have heard that, but Francis was saying that Molina doesn't currently have a separate process for credentialing providers for telehealth. Okay, should we move on to the next slide?
Yeah. So, I mean, my last slide talks about some pros and cons. I mean, it's really mostly pros with credentialing by proxy. It's a way to expedite the integration of telehealth practitioners into your hospital. It is, I think, time and resources savings. The cons are really if you're not able to monitor the regulatory compliance requirements that we've talked about. There's some lapse in the exchange of information, or someone falls out of licensure, and there's some consequence there. But for the most part, I really see it as a positive thing. One thing I didn't put on the slides was, I just thought of some ways that the collaborative could provide resources on this topic. I think it would be very easy to put together a template agreement that contains these requirements. A lot of facilities probably already have that, but we can provide that as a template, especially for some of the rural facilities that may not have that. And also put together some suggested bylaws language if you wanted to, or needed to update your bylaws to incorporate telehealth practitioners.
Helpful. I just know that the changing the bylaws can take a while.
Yeah.
So we've held up some of our programs. That's one of the rate limiting stuff that we talked about right off the bat.
Yeah.
Just make sure they're comfortable with that.
Sure, and I'm just saying, producing some language as a resource. If hospitals wanted to see how could we, what would that language look like? They would, of course, need to go through that lengthy discussion themselves.
Any other kind of experiences people have with this, or tips that you'd like to share? I think for us, the ironic thing, it's been harder for us to work within our own system in our own hospitals than people far away.
It is a challenge when you, especially with some of our rural partner hospitals, to have them sort of be on board with what we have going on. And really, in fact, we have a meeting, I think, tomorrow with one of our rural hospitals to just talk about our credentialing process a little more thoroughly so they understand what we're doing and the process we're following, in the hopes that it won't take 90 days to get docs credentialed, because that's some of the problems we have. That's, I think you put it right here, it's to be able to go live instead of months and days. It would be lovely to be able to do more quickly.
But in reality, credentialing does take 60 to 90 days.
Well, first off, but if you were already credentialed where you work and then you were going to be providing services someplace else, we definitely want to go through, I think, all the processes you need to do to ensure that you're providing the right care and you're where you should be. But it'd be lovely to be able to,
especially in a health system.
Yes.
That theoretically is all related.
Right, in your own house.
Great, thank you very much. This was super helpful. Appreciate that information. So next,
I'd love to get names from you.
Oh, sure.
That's great.
Maybe what I could, I wanted to go a little bit off script here, and I want to make sure that people had a chance to review the report to the legislature. Jamie, you included that. Yeah. Because that is due, it should be in the packet in front of everyone here, and also the email that came out. That is due on December 1st. I know we're pretty close to that deadline. But I just wanted to make sure that folks felt like it was accurate to what we were talking about. So just balance. So folks want to look at that. If there's any immediate feedback on it, but I'm also welcome any kind of offline emails that need to be added.
Hi, this is Brody. Can you hear me?
Yeah, go ahead, Brody.
Hi. So I just have a couple of minor edits that I could just send you, but the one that I'd like to bring up for discussion here is I recall in one of the previous minutes, I was trying to look through them, but I didn't have enough time to exactly find which date it was that I recall reading in the minutes for a previous meeting that store and forward was out of scope for the payment parity discussions, primarily because we haven't had a chance to really talk through it. Like all of our conversations about payment parity were primarily about synchronous video, and I think there was comments that yes, there may be some differences, but we never really got to talk about it. So I'm curious as to whether we could reflect that in the report. The reason why I bring that up as well is because in reviewing the draft legislation as well, it appears that store and forward is in scope for payment parity, and I just want it to be reflected that that was not particularly discussed in the actual collaborative meetings itself.
Yeah, I would agree with that. I think most of our conversations about payment parity was the live synchronous video teleconference. So we'll make sure that that is reflected. Check the chat. So we will send out the slide decks from today's meeting. Those should have gone out to the public. So Lisa, you might want to check your email. I think those went out the last day or so. Okay. So if I can just ask people to review the draft report for the legislature. I did go down to Olympia last month and gave about a 5-minute overview. Didn't get a whole lot of so I think they're pretty satisfied with that. Next, I want to turn over to Senator Becker, see if you wanted to talk about your proposed bill.
Okay, so the original telemedicine update bill I gave to you at the last meeting, and people were to respond to you. Did they respond?
I didn't get in.
Oh, so everybody liked it. We'll move forward with it then. I would like to be able to find out where we have areas that we totally agree upon and those areas that we totally disagree on, and what our next steps are, because I actually, in that last bill, we're done moving now and we're actually settled in, so I can read things again. But in that last bill, it was pretty, just a straightforward bill, and so we're going to drop that unless we get, meaning drop it into for hearings, etc. Unless we get some different feedback and we're willing to take a look at that. In the meantime, we've written 2 more bills, and Sarah came down to Olympia, and we sat down and had what I would call a pretty spectacular brainstorming session where we threw spitwads at the wall and what stuff we put into a bill, and then looked at it. And Safford, can you talk about them?
Sure.
Specifically, since you've worked on them more than I have at this point.
Stafford, if you could tell us the numbers, if they have numbers yet.
We don't have
numbers yet. Okay.
Well, the first one amends RCW 70.41.230. And this one is relating to physician credentialing in telehealth services. And there's a section in here, the third section, that's currently the law. Sorry, I have tape on my phone. And it's a telehealth privileges. It allows a distant site and an originating site to share privileging between each other when providing telehealth services. And the only change that's being made there is just including credentials in addition to privileging in telehealth services, so that the hospitals can share that information too. And you guys are the experts in why that's significant, but in discussing that was important to.
So this basically would enable proxy credentialing or kind of bless it. Is that the idea here?
Right.
Okay.
Yeah, the current law enables proxy privileging, so this just added credentialing and
Okay.
privileging to every instance where it noted privileging for Thomas.
For all providers, so they're
Yeah.
credentialed at the
Well-
medical center or just physicians?
I think it's the healthcare professionals or
It's identified under the RCW as the providers that
Deliver healthcare through that, yeah, services, okay.
it wasn't limited.
Yeah, and I did make two extra copies. I can provide one to Dr. Scott, or I can email it later if you want to send it out. Okay.
That was a small print I gave.
The next one is a new section. It would be a new law, and it deals with training for providing telehealth services. It specifically mentions medical doctors, doctors of osteopath, physician assistant certified, and nurse practitioners who provide clinical services via telehealth. And the training that would be required there would involve an initial training, a peer review process, which would involve a peer observing another peer performing a mock telehealth visit, and then also an acknowledgement of understanding form. And then that training would need to be repeated every 3 years. There's still discussion going on of who would be in charge of keeping records, or who would be in charge of making sure that this training is available, or that there's even universal training, or if the training wants to be relevant to each organization specifically. So that can be a discussion that we can have here. But I think it's also very important in this draft here that it's included that it's made available electronically on the internet, so that anybody can complete that training anywhere, no matter where you are, so nobody's advantaged or disadvantaged if you're in Seattle or if you're in one of the smaller towns. It also allows for, if for example, the department is the one who provides or administers this training, it allows third parties to also be able to provide the training, not just the department. And so they can go and do it that way, and they can provide that training to anybody. The other question that arises is who keeps records of the training, or who's completed the training, if we're going to require training to be done for telehealth providers. And I think that the record keeping would be piggybacked on who is decided is responsible for providing the training that needs to get completed. So that's where we're at right now.
Just to add one more thing to that, we also included if a health system has a telemedicine training process in place equivalent to whatever standard is in criteria or come up with, they can use their own process. So this was really to fill the gap for those systems that don't have training in place.
The other thing it does is it counts towards your CMEs. So,
Well, yeah, I put in there, I'm not familiar with the CME process, and so I put that it may count towards CME, meaning that if it goes through the CME process, that was my intent, that it could count towards it, because I'm not familiar with the CME process.
Yeah, those tend to have their own jurisdiction.
And so it didn't say that it will, I just said it could, but that paragraph could be taken out, because that's kind of obvious.
Couple questions. So number one, do you include physician assistants in that list of providers?
Physician assistants certified is what
Great.
I put in there.
And then some recommendations on the standardization of the content, and then what vendors will be responsible or have the opportunity to provide these training modules.
Mm-hmm. And that's what makes it easy about saying the department's in charge of the baseline training, because then they have the baseline training, and you can say vendors go to the department, and our department can approve the vendors or the organizations who have approved trainings, and then the department could provide a list of who the approved providers, organizations are that can provide that training.
I think that's a great way to do it. In the state of Washington, the licensing departments manage, for example, the suicide prevention training that's mandatory. And so they've got their vendors listed at their websites, and they've been approved, pre-approved. But then the renewal of that training is, and the responsibility of that training is on both the licensing department through their auditing processes and the providers themselves in keeping track of their own training. Does that make sense?
So yeah, the providers have to provide it on their
If they're audited.
renewal.
So the onus is on the provider to make sure that they're up to date. There's no entity responsible for tracking it on a routine basis, but if you were caught.
So it's not the department
during
keeping
an
records
audit,
of who's completed it, but it's done in there when you, excuse my lack of understanding. Because you do have to be licensed and recertified similar to attorneys. Is it every year or is it?
Every 2 years.
Every 2 years. So do we want to say every 2 years and then?
I think it's going to match up better with recertification.
That would be included with recertification.
Well, license renewal versus recertification.
I mean, sorry, license.
The one thing that I don't know, Stafford, is, or one thing that could be looped back is when the provider goes through a vendor and gets their training, does the vendor report that to the state? Does the state keep track? Because that would be another tracking.
And in this draft, because that was a question that I thought I had too, and in this draft I included that the training's not complete until the vendor organization submits the records to the department.
So I believe they have a responsibility to do that.
Right, and then the training would be incomplete until.
So then the onus would be on the Department of Health and the specific licensing department to enter that data, or whatever they do with that. Or if there's an audit, maybe they go back and look at those records.
Right, and so going back to your earlier point, if you do the training with your license renewal, then would you need the department to keep the records?
Well, theoretically, the vendor would notify the department anyway.
Yeah. So the department would keep records, and you do renewal.
But you'd also then, you have a backup of that because you have to sign an acknowledgement of your training. And so you should have that in your physician file or your provider file.
This is Tracy Drake.
Can
I add to this discussion?
Yeah, go ahead, Tracy.
At the Department of Health, we don't have any system to hold records for continuing education. We audit health professionals, so we don't maintain any records within our department. We don't have anyone send us records. So what it would be something within the law that requires something similar to the suicide prevention. And then you maintain your own records. If you are audited, you have to provide it to the department. One challenge with this would be, it seems to be the law is only for those who are providing telehealth. So I'm not sure how to put that in our rules requiring them to take it for their licensure renewal if some people don't provide telehealth and then are not required. So there would be some challenges with how to make that a requirement when it is up to the licensee whether they provide telehealth or not.
It also the onus could be, and the responsibility could lie within the credentialing facility who credentials the providers to ensure that the providers, when they come up for re-credentialing, which is typically every 2 to 3 years, depending on the facility you're in, that they ensure that their providers have renewed their credentialing, or they can't be re-credentialed for delivering telehealth services.
It seems like mirroring the language that we use for the suicide bill would be really strong. It seems like there's a process that could be very similar.
As for the record keeping or ensuring that the training has been completed.
Yeah.
And yet the variance there is that facilities are not withholding practice opportunities if you don't complete the suicide training. No one internally is really tracking that versus delivering telehealth services as a provider in the healthcare facility. Credentialing could be tied to that.
Is that the direction we're going to go?
Can you
Well, credentialing as a healthcare provider in the health center, in the health system, is not tied to completion of the suicide prevention currently.
Okay.
So if you're
my
going to do-
licensure is with the state, but my credentialing within the health system is not. But credentialing, could occur at a local level. And that could also be tied to each facility being responsible for that continued education, which I know a lot of health systems would appreciate, rather than outsourcing it, because that would be redundant. That would be more streamlined. And then there could be a second process available to those who are perhaps working in smaller entities that the law would still obligate them to, but they don't have an internal education system or process to provide this type of education. So there could be two opportunities to disseminate such standardized content.
There's a question on the phone.
Oh, this is Lori, Dr. Scott. I just had a quick question. Was there any mention of anything standardized in terms of the training content?
So just repeat Lori's question. Is there anything in the roughly page and a third bill on what's the content? Stafford, do you want to?
Can you say that one more time?
So does this have anything prescriptive, like what the training needs to have? What does the training need to cover?
Right. So the only section it says telehealth training course shall include training on current law, liability, consent, patient location protocols, and other criteria established by the department.
Can we make that in conjunction with this collaborative? So that this collaborative's voice is heard.
So that's I, section I, 1I.
Yeah, on the first page.
I think if the content mirrors what's laid out in the slide deck, we're going to be golden. It's very comprehensive and universally applicable.
But I can't remember. Would this training requirement apply to any healthcare professional that's going to be delivering services by telehealth in the state of Washington?
Yeah, here's what it says. It says medical doctors, doctor of osteopath, physician assistant certified, and nurse practitioners who provide clinical services via telehealth shall complete telehealth training prior to providing services via telehealth to patients located in Washington.
Does that cover mental health enough?
Well, it doesn't. Right, so two things there. Maybe we should change it to all healthcare professionals.
All healthcare professionals who require a licensure in the state of to practice in the state of Washington.
Yes.
And then the other thing is, this would apply then to groups like Karina, Teledoc, right?
So all health professionals who provide telehealth. How would you say?
The licensure piece.
All healthcare professionals who require licensure in Washington State.
For clinical practice.
We should probably cite to the license, if you're licensed under RCW 70, whatever it is. That'll cover PT.
Right. 7041.
I could send you, yeah, I'm not sure, but yeah, cite the range of the RCW for healthcare practitioners.
This is Cheryl Huchala. I've got a question.
Go ahead,
So
Cheryl.
are we saying that the telehealth vendors would be required to do this training as well? Like the teledocs and the...
Yeah, and Cheryl, my understanding is almost all of them have it already. I mean, Karina had the Karina University. It was very comprehensive, I remember. Do you have a particular concern though, Cheryl?
Well, I guess I'm just confused a little bit about what particular training, would it be additional training or they've already had the training so we don't need to worry about it? I guess I'm still confused about that.
As long as it meets the standard.
As long as it meets a standard, I mean, we probably want the DOH to review the curriculum. And if it's modeled off of what we've developed here, I think they're in good shape. when I looked at the Creating University, it was even more comprehensive.
So I think we have to be more prescriptive in this proposed RCW though. So we should probably be more clear. That document should be clear about who's going to have that responsibility of authorizing or blessing the content. So if it's left up to each individual entity, does it still need to, is it the honor system that they meet the criteria that are defined within the RCW? Or is there going to have to be a workflow developed at the DOH to bless each and every single one of these entities? And that you're going to get pushback on that.
Well, and I think it's also going to put a fiscal note in there that'll be on our list.
Right.
So we've got to be maybe less prescriptive than what you might be suggesting. I don't want to price it out of the.
How many entities would do their own training versus using one that might just be produced?
You could envision every health system that already has training.
They just want to do their own.
Yep. And then the national ones like Nighthawks, Teledoc, and Online Care Group, all of those.
So you could set a standard within the RCW, but then you have to ask yourself, what is the accountability and the potential for any kind of audit? If that's not going to happen, there's no policing in place, then it's truly the honor system.
What's the consequence?
Right.
I mean, the consequence, you get audited, you don't get your license.
But who will audit?
DOH.
But is it tied to licensure?
Yeah, it is.
State?
Yeah, that's what we're saying.
So does the RCW prescribe and mandate the DOH, and in that case, where would that land? I mean, again, I'm just thinking on the back end, just knowing, having more intimate knowledge of how DOH, just the resources are slim. And so stacking something else on, and like what Senator Becker noted, the fiscal note would be so big that this would not get, it wouldn't get through. It just wouldn't get through session.
Well, one thing it reminds me of is within our state home care rules, there's a requirement that the home care personnel, their unlicensed personnel, that they have to undergo background checks and certain trainings. And that is basically honor system. And so it's written into the rules that they have to, the personnel have to undergo that training and keep it in their file. And then that is audited from time to time. You don't have an audit mechanism set up here, but when that has been audited against home care providers, then that has affected the license status of the home care provider entity to do that work. Here, it would affect, the license we're talking about is the physician license. And our unprofessional conduct statute says if you're non-compliant with any element of the physician licensing rules, it could be deemed unprofessional conduct and affect your license. So it could be honor system to begin with to avoid the fiscal note. We don't really have an auditing plan yet, but could maybe think about that. But the back end enforcement would be that if it was identified on an audit, then the medical commission would have discretion to either write kind of a letter input saying you need to do this, or if it was multiple times or in combination with other unprofessional conduct acts, they could take enforcement action. But the missing piece, I think, is would there ever be, how and when would they ever audit? I don't know. But they have that. I mean, the commission has discretion to review and audit physicians for their, for anything. They do investigations all the time. Yeah. So it could be just part of the realm of things that they would monitor and investigate if they.
Kind of like your CMEs.
Right. Yeah.
It's in your file.
And if you were asked to produce it, just like on the home care side, you would have to produce it. And if not, then the commission would have to decide how to handle it. It's not like clearly articulated, but it does kind of fit within a regulatory scheme. But that's one of the physician licensure requirements that they would monitor and audit if they wanted to do so.
And we'll be talking with the Department of Health as well, showing them this, but we'll make the revisions. I think there's some good revisions.
Any other questions or comments? Or move on to the third bill.
Well, one thing is when we have the hearings on these, I'm going to have to ask you all to call into the chairs and ask them to hear these bills. And then you'll have to come testify so that they know that there was a really a big effort to do this and do it right. Would be most helpful. Otherwise, we're going to be stymied because I don't know how many bills are going to come through.
Can I ask one question?
Yes, go ahead.
Hi, this is Josh Frank from American College of Emergency Physicians. I was wondering, what is the current routine for when you audit, say, CME or other elements? Is it on a kind of a case-by-case when there is a concern basis, or do you have a kind of a rolling, standing, so many physicians at so many intervals?
I can answer that question.
For the commission.
Go ahead, Tracy.
The Department of Health audits all health professionals, including the commission, the MQAC professionals. They are audited a percentage every year. It is a random audit. So I believe it's up to 20%, although it's usually not. In the law, it says up to, so they may do 10%, they may do 15% that are audited each year for their continuing education. At that time, they provide proof that they've provided the continuing education. One concern I have with this law coming forward is the fact that I don't know how we can get proof that somebody is providing telemedicine. So if we have to audit for continuing education for telemedicine and someone just says, no, I don't provide telemedicine, therefore I'm not sending this in, how do we prove that they are providing telemedicine and that they should have taken this course?
Yeah, that's where either the insured, or Medicaid, or.
Well, it
Yeah.
needs to
Can I?
ask a question. Because tying this and getting this training is just not to provide training, just as a random, everybody needs to be trained, but kind of a requirement to the carriers that when they're going to pay for these services, they know these people have been through the training so that they know that they've met that criteria. And so I think that opens up another part for me. I'm all for training, but not just for the sake of having training. I think that it then ties into the carrier's ability to pay for it, whether they've completed that or not. And so usually that's an addendum to a privileging or credentialing, not privileging, credentialing that you send in, and then the carrier actually knows that has happened, and then can pay. And if somebody bills for telemedicine that is not sent in that addendum, then they will get a letter saying you're not qualified, you haven't gone through the training to. That's how I'm assuming it would be, or a denial based on the fact you haven't met this criteria.
Is that how it's working?
I think that would be not now, but that would be a great idea to have this a common course or a bar, basically a standard
Right.
that all telehealth providers across the state have to, at a minimum, adhere to. And then add that into part of the documentation required to credential them, forward. Because you're right, the way that we identify how many, we're surprised how many providers, mostly physicians, some nurse practitioners, are providing telehealth services, and it comes in through the billing. We just know that because of the modifiers in place of services, but otherwise we wouldn't really know how many. And it's surprising, especially on the telepsych side, how many visits we pay for every year that are connected via telehealth, and but we don't credential the providers differently. So this is a really important point to take back and figure out how we're going to kind of incorporate that. We have more and more providers in these rural areas, and we're promoting it. It's just that we just need to have this other piece of it built into this credentialing process. So,
another consideration is there's a larger cash pay, self-pay market in telehealth services as compared to in-person services. So you can get a lot of claims, but how would you capture all those? For example, I myself just send a picture of my skin rash to a dermatologist online that can diagnose it and send it back, and I just paid them money with my credit card over the internet. That wouldn't be captured in the billings. So how do we identify those providers that are required to have the training?
Well, those providers might be in another state
They could be
too.
They need to be licensed here.
If,
right?
yeah, if they have.
Hopefully.
So to your question, how do we know if you're providing telehealth services? You tell me, oh, I'm not doing it, but maybe you are, or you don't understand the question, or you want to get around the training. How do we audit?
A couple thoughts. I mean, I think if they are licensed, they come up on periodic, 10 or 20% are audited each year. Another way that audits or investigations come up all the time is complaint-based. You know, if you were misdiagnosed for this skin issue and looked up the provider on the MQuack website and he or she wasn't there, you could, you know, and presumably a company like that would hold itself out through an app or a website as a provider of telehealth services. So we would know they're at least positioning themselves as providing telehealth. Therefore, they would need to comply with state law requirements and go through the training.
Maybe we give them a credential that they can display on that website then.
Yeah. Yeah.
May I comment on that?
You know, Carrie is a heavy lift in a very different way. And although I think that it's a great idea to be perhaps heading in that direction, one consideration is that, you know, most providers have, especially if they also carry a certification, you know, continuing education comes at a pretty significant cost, not only monetarily, but time away from work. And so on the one hand, I think having a regulatory mechanism is where the teeth is going to be, and certainly an audit team operation. However, I think we're going to have higher complaints rates with system providers on the term where it's free to them, and the onus is more on the health system to provide this if they have credentialed providers in telehealth. And then having perhaps written into the RCW that in the setting of a vendor of telehealth services who are providing services within the state of Washington can go through one of the registered vendors with the state. So that there's options and, you know, thinking through how we ease the way for providers so we're not creating yet another barrier. And to be able to demonstrate that in the verbiage of the RCW, that we're not trying to make this more difficult, but to build the safeguards and the quality standards necessary.
Josh, I think Dr. Frank wanted to say something, and then Dr. Kia. Josh?
Yes, if I may. Thank you. The comment on the last gentleman about being on a complaint basis, I hate to think about a way of monitoring being on complaint basis because it's nice to catch things before that occurs. But there's a lot of things that we do which are tools, procedures. I mean, emergency medicine, we have intubation credentialing. We have procedures that some physicians are used to and are trained on and others aren't. So they won't use them if they know that they don't have experience on them. These are all subtleties to the specialization and the training and experience in different facilities, and we're responsible for our own experience training, and then the credentialing departments at those facilities also monitor that as well. And for the state to keep track of all that would be too much. But if there is a complaint or a sentinel event or something like that, then of course that gets looked at very carefully. It seems like philosophically you're talking about wanting telemedicine, the use of that technology to be something that becomes a tool that's regularly used by a lot of physicians, hopefully. And so separating it out into a separate kind of monitoring system, it seems a little counterintuitive. It seems like the idea of sticking with the standards of how other tools that are regularly used by many different physicians is a little bit more in line with what the goal is. And so the standard of if there's a complaint, if there's a concern, if there's a sentinel event, something like that, triggering a commission to look in and make sure that the physician has been responsible might be preferable to a rolling, 15, 20%, and some way of trying to figure out if they've ever billed for telemedicine, that kind of a real complicated system.
Thanks, Josh. I think your colleague, Dr. Kie, wanted to chime in as well. Ryan, are you there? If not, I will read her comment. So she said her comment is that CME or training is designed to ensure proficiency around patient care, not as a part of the payment negotiation. And then she just reiterated the point that self-pay providers will likely not be identified.
Hi, thanks. I was on mute. I just was, it's a she, not a he, but that's okay. I just wanted to speak to that for a minute. I always, I think CME and training requirements are really important. I think when we talk about excellent delivery of telemedicine care, we need to talk about patient-centered factors and metrics. And I always get nervous talking about CME as a way of reassuring payers that you have the appropriately credentialed people. It's just a framing of the conversation is all I'm talking about. And then in terms of self-pay providers, I think this is a really interesting conundrum that may not be able to be solved, or providers who service self-pay patients. This may be a really interesting conundrum that I don't know this committee is going to be able to solve. The proliferation of concierge medicine and self-pay and the lack of sort of, I don't want to say lack of regulation, but there is some lack of regulation around that if you don't take CMS dollars, is a big can of worms that I think hasn't been tackled anywhere. So I will go back on mute.
Thanks, Ryan. Does that help you out, Senator Becker?
Oh, yes. I think it gives us a lot of ideas that we're going to have to, Stafford, we're going to be sitting down and really talking.
Is there a third bill that you wanted to talk about?
We've gone through the parity bill. We went through the
I think that is the three. The parity bill
Yeah.
we talked about last time. Okay, great. Well, good. So we're in the home stretch here. One thing that we have not talked about, and that was in the original legislation, was that we were tasked to comment on developing a technical assistance center. We have not talked about that at all. Maybe if I can, Senator Becker, what was your kind of idea, what was your vision for understanding or exploring that idea a little bit more?
That's been a while. And it seems to me, if I'm thinking of a technical support system, it's kind of like a peer-to-peer, where people have a place to go in and look at all of what they're doing. I don't think that it's all that different from what we've been addressing. I think we've added enough. If we add too much, we're going to wipe it out.
Okay. Yeah. I mean, and that's why I wanted the NRTRC to come and speak to us last year. It might be just a good reminder of what they do. There are several states that do have technical assistance centers, and I think they were really developed maybe 10 or 15 years ago. That technology was super expensive. And so they're basically sharing server space and things like that. So if you want to do it, I can just look at what they've done.
Sure.
And maybe there's something that's not being covered by the current activities in NRTRC.
I mean, when the NRTRC gets a TA call, technical assistance call, they're not specifically talking only about technology.
Yeah.
It's oftentimes questions about credentialing or training or, various resources. Where can I find a resource? That kind of thing. So it's not specific to technology. There is the technology telehealth resource center based in Alaska, but it serves the nation. So they really focus on the technology piece. And all of the TRCs across the nation kind of collaborate with each other. So if the NRTRC gets a call that's very tech heavy, then they might refer them to the technical TRC.
It reminds me that the NRTRC had their annual conference in October in Salt Lake City. I'm just wondering, did you go? I'm wondering if next time, if you could be willing to kind of give a little bit of an overview of some of the best of new things that would be folks take on.
I attended, this is my first year attending, and it was one of the best conferences I've been to in years. I will say that. and we've gotten a lot of like actual action items and follow up with other health systems around our region. So I'm looking forward to the one in Alaska in August. Yeah.
All right. So next, Jamie wanted to talk about our schedule for meetings. So Jamie, do you want to talk about when and where we're going to be doing them?
Sure. So, so one of the things when I first came on board is I asked Dr. Scott, like, when does the group normally meet? Is there a set schedule or anything? And he said, no, we usually just try and schedule things like every 6 weeks or so. And I said, so one of the first things I did when I came on board was kind of look back at when the meetings took place. And you'll have in your packet here kind of a little spreadsheet I put together, just a really simple thing as to when they came, like when we typically met, and if there was any pattern to that. And I know a lot of times we always have to work around the session, so wanted to make sure that wouldn't be an issue. And then of course our doctors, we have to make sure they're not in clinic or anything like that. So basically what I did is I put a proposed schedule together based off of what we've had in previous years. So as you'll see, my next proposed date is January 3rd, because we've typically been around the 4th or the 5th. And then going forward, like some months we always had meetings, other months it was, well, we had one once, so maybe that works. So I just threw this together, kind of tried to stay on that same path, cadence that we've had in the past. And as you'll see, most of them are Fridays because those tended to work pretty well for most people in the afternoons on Fridays, and then a couple during the week. So I just wanted to throw it out there and see if there's any big glaring issues that I may have missed in this schedule. And then at least, if nothing else, if we can try and get the next date nailed down.
So for us legislatively, I don't have my legislative calendar yet. So when we're on the floor and taking votes, there's no way
absolutely
I can be here or probably others.
Mm-hmm.
And staff even can't come when we're on the floor. So that's a critical time. Fridays are the best as far as the legislative part, because they try to, at least when we were in the majority, we kept Fridays light because a lot of people had to travel home. But I don't know what the schedule will be. We will know within the next 2 weeks, at least the committee times, etc. Because we're all trying to do that part of it.
And the session starts the second Monday. So like,
January 14th, I believe. Yeah. 14th.
So we were talking about January 3rd, which is a Thursday.
Yeah, it would be in the morning.
Where?
That is also something else we're going to hopefully talk about, is see if we can get a volunteer to host.
Well, and I don't want to put Stephanie on the spot, but I will, because I know that Multicare has hosted at the Coma General, and they've had a really good room and a good technology setup. So I'm wondering, Stephanie, if you would be willing to ask your colleagues about finding a space at TG for January 3rd.
Yeah, absolutely. I will find out today if there's a room open and get back to you. Yes.
Yeah, we're looking in the morning on Thursday. I'm on service. I have to do inpatient duties in the afternoon, but in the morning I should be able to get down there.
Okay, perfect.
Thank you. So maybe we'll put TG and Multicare as a. Does that work for you? Is that better? I mean, I know for folks on that.
It's just that at least I don't live in Eatonville anymore, and I'm closer to the freeway. You know, it's still over 2.5 hours to get here. So.
And I did throw February on there again, but that was one that we only had a meeting once. I didn't know if that would work with session or not. I did add that on a Friday in case it was possible. So I'm assuming that Thursday the 3rd seems to work for everybody. Okay.
Afternoon or morning?
Morning.
I teach on Fridays.
Okay.
On that quarter, but that's fine.
Okay.
January 3rd is a Thursday.
I'm looking at February. You were just talking
yes,
about February.
so February. Is that so? If want to talk about any of the other dates, I'm happy to do that right now, because if we can get them settled.
I think Providence/Swedish could be on the February or the March dates.
Okay.
And also,
You know, that we had a major technology issue. We could not.
So Adrian,
Bank of America.
we have a lot of portable stuff.
I was thinking the Bank of America.
Oh, great.
Okay.
Yeah, this was in James. Yeah.
Oh, the James Tower. Yeah, I think that the Bank of America.
Okay.
And that's right off the freeway.
Downtown. Seattle.
Early in the morning. Where's
We can also do the
Oh,
rent.
yeah, could do the rents. Yeah, that might be, yes.
Being a conference. And also for Fridays, we'd like to do afternoon times.
On Fridays?
Yes.
Yeah, I like that.
Yeah, so we can either.
So any of these dates that have a Friday would be afternoon.
So when we just tentatively say the 8th, and I'll get back to you.
Excellent. And March, so I was looking at that last week. So if there was anything in particular that if we want to stick with a Friday cadence, anybody have any thoughts on that?
During session would be probably the only.
Okay. Okay, so I believe that was either the 22nd or the 29th. Those are both on Friday. Any preference for you guys? Okay.
At least we got the next two ones.
All right. Yeah, and then there was a couple others that had some options. When we get into May, that was a Monday. I don't know if that's possible for session or not. Or
I hope we're
schedule.
done. We ended, no, it's a long session this year, 105 days, so I think it's April 28th. is when we're supposed to.
Okay. So May would be the beginning of May. In June, I have again either Thursday or Friday towards the end. Then we're off in July. That seems to be the cadence. And then August, I had recommended Thursday the 22nd. September, there was only one year that we had something in September, so I didn't know if that was preferred or not. So I wanted to throw that out there. And then I had the last meeting of the year, November, around November 15th. That way we're kind of out of the holiday time.
So if folks can look at those dates and see if they're willing to host, or if people have strong opinions of where they should be. I mean, so we've been trying to move it around. I'd say we've had about 70 to 80% of people host. Lori, I know we haven't had the privilege of seeing beautiful Vancouver, and we do have pretty good portable technology now, kind of a teleconference in a bag. So if you have decent Wi-Fi, we could probably do it down there. I know that was one of the concerns.
Sure, we can look into that again.
Okay.
And also just one of the reasons I wanted to do this too is I thought maybe, so for example, Dr. Scott mentioned having maybe someone from NRTRC could come out and speak with us. You know, we can get that scheduled if we know the dates that we're gonna have the meetings ahead of time, and we can also kind of talk about if we want to bring any of the bills back when we want to do that and get that scheduled out ahead of time as well. So.
Thank you for putting this together.
You're welcome.
I think we got a couple more minutes, like 5 more minutes for public comment period. So if there's anyone who would like to ask a question or raise an issue, member of the public, we can open the floor both in the room or on the phones.
This is Tracy Drake. Is it possible to get a copy of the proposed legislation so that it's something that we can discuss at Department of Health, so I could look at comments? Are we at that place yet?
Do you want to do this copy, or do you want to meet and make these changes?
Tracy, if you wouldn't mind, this is Senator Becker, if you wouldn't mind, Stafford and I will sit down and make a bunch of changes on this and then send it over to you.
That would be wonderful. Yeah, that would be great.
I think it'd be better.
Thanks.
This is Marissa, Coordinated Care. I just want to add my appreciation to staff getting materials out in advance. I find the slide deck as a non-practitioner of anything. Really, really helpful. So I'm very excited in the direction that that's going. And I also appreciate having some dates in advance. I think that will really help. So thank you.
Great. Okay. Any other comments? Well, great. I appreciate everyone for making the drive. Hope it's better going home. And we'll see you next time. Happy New Year, everyone.